Hello, guys, and welcome back to NCLEX session. We started off with NCLEX session medication uh, part 12. That was the introduction to medications in general, the type of questions for the NCLEX exam. Pretty simple and basic ones that you'll see often. But today's video is specifically about medication administration and how the five rights of medication administration has expanded into a comprehensive 10 rights that shape self-healthcare practices. So in general, first of all, let's tell you a little bit about myself. My name is Diane Anderson, and I am a professor, and I have a master's degree in nurse education. My background expands over 20 years. It starts with critical care, ICU, PCU, IMC, ER. I've done both pediatrics and adult, as well as occupational health, as well as home care, as well as prior authorization nursing for an insurance company. So I've done quite a bunch of different things, and I have a really great background in nursing in general. And I'm still in the hospitals today dealing with the critical care patients as well, in trauma care and cardiovascular and neuro ICU. So, first of all, again, thank you for joining us. And before we get started, please go ahead and click that like button. And if you're already a subscriber, thank you. And if you're not, please join us and subscribe. All of your support when you click the like button and also when you add a subscription, it helps us to be able to put out more and more videos for those who either cannot afford one-to-one counseling and tutoring, and they just need free education online and free education through YouTube. So this allows us to do that and help others. In addition to these videos, if you do need one-on-one tutoring or you prefer that, we will have some information at the end of the video about contacting us and setting up a time that's best for you, whether it's day, night, or evening. We're very flexible with our times because the main thing is to see you succeed. That is our whole point, is making sure that you succeed in your career, in your journey, in your education, in your field. And also, if you're even seeking out getting your master's degree or even higher, let's talk about it. We can talk about different areas of nursing that nursing has evolved and progressed to. Is so many different fields, whether you're talking about forensic nursing or nurse anesthetists. I mean, it's so much out there, and bedside nursing is great, but pretty much that's really a foundation. For some people, that's the end all be all. That's wonderful. But for others, it's just getting them started and they want to then branch out into other areas. I'm there for all of the above. So let's get started. This is a pretty easy video for you to, understand the concepts. It's just pretty much a review of what you've already learned. I'm just summarizing it for you and bringing focus and emphasis on the importance of it. So we're going to end with a few questions as well to kind of bring that knowledge to the forefront and apply it so you see how it actually affects day-to-day care in the hospital setting. Okay, let's get started. So in general, the concept of expanding the rights of medication administration from 5 to 10 emerged gradually over time with discussions and advancement in healthcare safety protocols. And that was mainly done by a lot of research that found that we still were having many, many errors with patients and medications, even after applying the five rights, because then other issues came up like, does the patient have the right to refuse medication, whether they're pediatric, adult, or whomever? Or other issues pertaining to medication. So we're going to go into that in a little bit more depth in a few minutes. Okay, guys. Well, you should know the first five rights because this is where it all started. So let's quickly just review that before we go into the 10 rights. So the first right, the right patient, confirming that you have the correct individual by checking identifiers like their full name, their date of birth, or their hospital ID. And I say or, but most facilities will have you check with two checkers. So it may be, well, it should always be their name, obviously, but it's usually their name and date of birth, or name and hospital ID. Frankly, I check all of the above because I have been in many situations, oh my God, where I had two patients that had the same first and last name. That was very scary. And I say that because when you're pulling your meds, you're like, oh my God, you're going into the computer and you're pulling that person's name, but it could have been the other person, when you're hitting that button and you're just looking at the name. But when you go to the bedside and you say, okay, wait a minute, the date of birth is separate and different, because that's how I found out the date of birth was not the same and the hospital ID did not scan. Then come to find out, they hadn't put they supposed to put like a little marker in the computer, like a little red flag, to show that they're two different patients with the same exact name. Sometimes that happens, and sometimes an error occurs, and either the pharmacy didn't get the memo, or something happened and it just didn't get loaded up into the computer. And then now the nurse is stuck in a situation where they're at the bedside and they got to make sure they know their rights, because if they don't, they could give the wrong medication to the wrong patient just because they have the same name. So that is a huge one. You're going to see that a lot. Unfortunately, it is still happening. That actually just happened to me again, literally a couple weeks ago. They gave me two patients with the same name. When the charge nurses are giving the assignments, they never should give the same nurse two patients with the same name. But does it happen? Yes, it does, unfortunately. If that ever happens to you, let your charge nurse know so she can change the assignment immediately to protect the patient. Okay, guys, sorry that was a little long winded, but that's really important and really crucial. And unfortunately, it's still happening in 2023. And I'm like, really? So, yeah, you guys really need to be aware of that. Don't just trust the computer and what the pharmacy has in the computer and what you see on the board. Really thoroughly check to make sure that is the correct patient and date of birth and hospital ID. All three really should be looked at. Okay, moving forward, the next one is the right drug. Checking that the medication matches that prescription detail, the name of the drug, the dose of the drug, and the form of that drug. Is it a pill? Is it IV? Is it IM? All that stuff. Very, very critical. The third right is the right dose. So you want to make sure you're given the right and accurate amount of medication according to the prescription. With some medications, you have to factor in the age and especially the weight and the condition of the patient. And when I say condition, you might be like, well, what does she mean condition? Is the patient stable, like their vital signs? Let's say, for example, you're giving a blood pressure medication and the dose is the right dose and it's 25 milligrams, let's say, of low pressure, also called metoprolol. Okay. But yet the patient's condition is in a situation, let's say that they're losing blood and their blood pressure is dropping quickly, or they are dehydrated and they have a low blood pressure because of that. That may not be a medication you want to give, even if it is the right dose. But looking at the condition of the patient, that dose, even if it's only 25 milligrams of metoprolol as opposed to 100 milligrams, which I've given a patient before in a pill form, I wouldn't even give the person 25 milligrams if their blood pressure is constantly dropping and we don't have enough fluids to maintain that, or their condition is getting worse and worse. I would put that on hold and consult with the doctor and the pharmacist about, should we be giving this medication right now? Look at the condition of the patient. So that's what I mean by condition. Weight is a huge thing because a lot of medications are weight based. When was the last time the patient was weighed? Are we going by a weight that was done a month ago and the patient has been here for 2 months and the patient's now not eating, not really drinking much except for the IV fluids we're giving them? Has the weight fluctuated enough where the drug should be a lower dose? Has anyone even checked that? Because guess who's that's going to fall on if something happens to the patient? It's going to fall on the nurse. It's not going to fall on the doctor. It's not going to fall on the pharmacist. It's the last person that's giving that, going to that patient, that last person that saw the patient before the patient actually swallowed the medication or took it in their IV or took it in their um, intramuscular injection or sublingual under the tongue or intradermal, which is underneath the skin. So it'll be that last person that's in trouble. That last person will always be the nurse because that's usually the person that's administering the med. So you have to factor in everything: age, weight, and condition when you're looking at that right dose. Don't just look at the dosage of the medication. All right, next one, right route. The right route. Are we administering the medication via the prescribed method? Did the doctor write PO, which is oral? Did he write intravenous, which is IV? Did he write intramuscular, which is IM? Did he write sub Q as a sub and the letter Q, or just SQ or SC? You'll see it written in all those ways because he's never going to write the whole thing out subcutaneous. They're not writing all that. Everything is usually abbreviated. Um, or is it a swish and swallow? Like a nice statin medication for thrush in the person's mouth. That's a swish and a swallow. And then we have other medications, which is a swish and they have to actually spit it out. So, what is this method that you're doing to administer the medication? Make sure you're aware of it, understand it before you go in there and even be at the bedside at all with that patient. The last of the 5 rights is the right time. Ensure that the medication is given at the correct scheduled time, accounting for meal times and potential interactions with other medications. I'll give you a quick example. Synthroid. Synthroid is a medication that usually when I give that, even if I'm giving it through an NG tube, which is a tube through someone's nose, down their esophagus, into their stomach, etc., and there's someone that maybe can't swallow, and I'm crushing the medication and adding a fluid to it, so a little bit of water to dissolve it, and putting it through there via a syringe. Regardless of whether I'm doing that or whether the person is actually swallowing the medication or whatever, the question is, okay, did I give it at the right time? Because Synthroid, for example, should be given an hour before. Let's say the person is on a tube feeding. That's why I'm bringing up a person with the NG tube specifically. Let's say they have a tube feeding going through that, or let's say they have a G tube, a tube directly in their gastric area, and or we also call it a PEG tube, and you're giving that medication. That medication specifically wants you to turn off the tube feed for like 2 hours, then administer the Synthroid, let that sit for like an hour or so, and then restart the tube feeding. It really shouldn't be taken with meals. It shouldn't be taken with other medications. And Synthroid is uh, a steroid medication that you're going to see a lot in the hospital. And that's just one of many that could interact with other meds and interact with even the food. So ensuring the right time is huge. It's not just, okay, well, he wants me to give it at 12 p.m. It's 12 o'clock. I don't see the problem because you also have to see what that medication interacts with. That's what you're looking at. Perfect one too, insulin. That's huge. So many diabetics in the world, whether they're type 2 diabetics or type 1 diabetics. Um, if you're giving insulin, did you check the blood sugar? And if you check the blood sugar, and when you check the blood sugar, was it after the person ate or was it right before they ate? Usually you should be checking the blood sugar right before meals, right before breakfast, before lunch, before dinner, and right before going to bed. The doctors may give the patient a different regimen for them to follow when they go home to make it easier for them. But for the purpose of professionals that work in the hospital setting, we are checking the blood sugars prior to each meal. And you'll see it written as AC and HS. AC means before meals. AC before meals. HS means hour of sleep. Also, it means bedtime. Also, it means usually anywhere between 8 p.m. and 10 p.m. at night. Check that blood sugar because we're going to give insulin based on those numbers. Okay. Because if they're normal, level, that's fine. Go ahead and let them eat their meal. They're fine. But what if their level is 400 or 300 or 200? more than likely they'll have a sliding scale written out so you'll know exactly how much insulin to give them. So the right time is crucial with medications. And those were just two examples of the millions of examples that are out there. So remember, these 5 rights ensure safe medication. Okay. And mastering these principles is key for safe nursing practices. We want to administer the medications safely. But there has still been issues. So let's go through that. Okay, so again, just a quick review before we head into what new rights were added. But quickly, right patient, right drug, right dose, right route, which we just discussed. And remember, number 5 was the right time. So the following was now added after expansion. We have the right documentation. That's just about accurately recording the administration details promptly and comprehensively. So we know what you did, where it was. So, for example, I've had in the past, I've had nurses that have given injections, and it's good to rotate the sites on a patient. You don't want to keep using the same thigh, whether right or left, the same arm, the same whatever. You want the body to have a chance to heal in between these needles. Unfortunately, jabbing at the skin, I mean, we weren't really made to be pincushions. So we need time to heal. So it's not good for another nurse to go in the same spot, same spot, same spot. It makes it harder for the patient to heal. Okay. And then they'll develop other problems as well. So right documentation. So if I have someone that gave an insulin shot, they should be saying, was it in the, let's say, the right lower abdomen, or upper right abdomen, or upper left or lower left, or behind the upper arm or behind the lower arm, and where exactly that was. So we can be rotating sites for that patient. And also, this is a huge one. Why would the right documentation be important too? Because let's say, for example, this is happening everywhere worldwide, whether you're a school teacher, whether you're a nurse, whether you work in certain facilities where you have to have be tested for tuberculosis and TB, which is the same thing, TB or tuberculosis, however you hear it said. When they give you your shot, they have to go back and look at that area where that shot was and see if it has become red and swollen and has evolved over the 2 to 3 days after you've gotten the shot. Well, if you don't know where the nurse put the needle at and gave you that shot and administered that, the person that's following up to check to see if you had a reaction to that PPT shot won't know if you did or not, because they won't even know where to look, because it may not have been documented where the injection was actually placed. So documentation is crucial. The next thing is the right assessment. Again, going back to what I was saying, condition of the patient. You evaluate that patient's conditions and any factors that might affect the medication's efficiency or safety. Again, like I used the blood pressure issue as an example before giving a blood pressure pill. Is their pressure way too high and they really need their pill? Versus their pressure is so low that if I give this pill, this might actually kill them because a little bit of pressure they have, I'm going to take it away when I give them this medication. That's huge. That's not something the doctor deals with. He writes the order based on when that patient was admitted into the hospital, based on that baseline that they see that patient at, as they write their slew of orders to get that patient, admitted to whatever unit they're sending them to. Well, a lot of stuff can change between the time the patient is admitted into the hospital and, let's say, the 1 to 2 to 3 months that they're still there. It can be anywhere from the patient's not eating right to other issues that happen to them and other conditions have gotten worse. Maybe it's their kidneys failing, maybe their heart is failing, maybe something going on with their gallbladder, maybe something going on with their liver. Their liver is metabolizes a lot of medication. It's one of the jobs of the liver as well. So if something is going on in their system, or you can see something in their blood work that could affect this, it's going to affect the medication, how the medication works within that person's body. Is a doctor thinking about all that stuff when he's writing the orders? No. Why? Because that's the nurse's job. It's both of our jobs. But in the end, it's our job because we're the one that's administering that last protection prior to giving that medication to the patient. And if we see something wrong, we should be halting ourselves and notifying that physician and even the pharmacy of what's going on so we can make alterations in that medication. So assessment is huge. Right education, providing that comprehensive information to the patient about the medication, what its purpose is, and potential side effects. So I'll just give you a quick scenario. For example, when I go in and give my medications to my patients, and I say this to my students as well, as I'm I've already checked the patient, make sure there's a right patient, right time, all that other stuff. Okay. Now I'm scanning the patient's armband, scanning the medications. Most places are using barcode administration for meds now, which is the little scan gun, the same ones you see at the grocery store, but you're scanning the barcode on the patient's armband and you're scanning the barcode on the medication. So as I'm scanning them, and I already know now that all these medications that I'm scanning now, I know these are the right patient's medications, and even though the patient may already know about their medication, as I'm opening them, I'm saying stuff like, okay, this is your low pressure. This is for your blood pressure. Remember, I just took your blood pressure like 2 minutes ago and it was 210 over 95. This is going to bring that down. And as I'm opening them up, I'm putting them in a cup so the patient knows what I'm giving them and why they're getting it. For example, when I'm doing Lasix, I might be saying something like, okay, this one here is Lasix. This is your fluid pill. Not only is it going to bring your blood pressure down and get some of that fluid off your legs or out of your lungs or whatever that doctor ordered it for that patient for, but also, unfortunately, sir or ma'am, I'm so, so sorry to tell you this, but you're going to be getting up to go to the bathroom a lot because this Lasix is going to run right through you and you're going to be constantly urinating, constantly going. I mean, literally, I'm giving it to you IV. It's going to be working about 5 to 10 minutes. You're going to want to get up and go. Or I'm giving you a pill in about 20 to 30 minutes. You're going to be barely making it to the bathroom, which is why I put a bedside commode here beside your bed. Or I have you closer to the bathroom. So this is what you should be saying and teaching. You can be teaching as you're opening up each medication because you're supposed to already know what the medications are for. That's why you went to school. That's why you learned what you learned. And if you're not sure about a medication, you should be looking it up before you even go in the patient's room so that you know what you're giving and why you're giving it. So if the patient has any questions about it, like, I don't understand what is that blue pill again? And then you can tell them, oh, it's such and such a pill. It's for this particular thing. And yeah, this is what it's for. This is why it's ordered, and this is why you're getting it at this time. So just general information about the pills you're giving, not reading them the whole textbook or medication book, but just general information. Okay, really huge. Education is key. I know I went and got a master's in education to teach you guys, but guess what? All of you are teachers. You're all teachers, and you know that. You're teaching the patients every single day. And if they have loved ones that come in, you're teaching them too, especially if the patient is a confused person that has, let's say, dementia or Alzheimer's. They can't remember what the heck you just told them. They'll forget everything you said, usually within about 30 seconds after you said it. And you're like looking at them like, do you remember what I said? And they're like, who are you again? Oh yeah, oh, you're who? Are you Betty from next door? No, I'm your nurse. I'm your nurse. I'm here to uh give you your medications. Remember I just told you that? So yeah, they're like that, unfortunately. So a lot of times you're teaching the family member that comes to visit them at the bedside or the family member that lives with them all the stuff about the medications and why it's important and what it does and side effects and why it's important to give it these certain times. So education is key because you're going to be teaching someone, whether it's the patient or their loved one or caregiver. Okay, the last two, the right to refuse. So in this situation, you're acknowledging and respecting the patient's autonomy to decline medications after informed discussion. And when I say informed discussion, I mean you fully explain the medication. This is why the doctor ordered it. This is what it's for. This is why I'm giving it at this time. This is a potential side effect that could happen. Like for example, I'm giving you this blood thinner and it's a prophylactic. It's a prophylactic for DVT. So let's say it's preventing deep vein thrombosis or blood clots is a more simple term for a patient. Tell them blood clots, not DVT or DVT prophylaxis. They'll be like, what the heck are you talking about? So it prevents you from developing blood clots while you're here laying in the bed because you're not up and moving about as much, and therefore you may develop blood clots in your legs, and the blood clot will go to your heart and literally or to your chest and cause a pulmonary a pulmonary embolus and make you not stop breathing, or the clot could go to your brain and cause a stroke. Now, you're not going to say all those details and scare the poor patient to death, but you're pretty much saying, I'm giving you this medication to prevent a PE, a pulmonary embolism, to prevent a stroke. So that's what this medication is doing. I've said all that to patients, and I still have patients say, nah, I'm not taking that. I don't want that needle. I know what it's for. I know what it's going to help me do. I'd rather just get up and walk around a little bit more and circulate my blood that way as opposed to getting that. Or I'm not going to take that. I'll do the SCDs, the sequential compression devices that you guys put on my lower legs that squeezes them, contracts it and let go, contracts and let go. It's like a nice little massage. That also gets your circulation going. And that could be used instead of giving a heparin or a Lovenox, which is another medication to prevent blood clots. Okay. So I've had them say that, and they have every right to say, I do not want that. I know what it's for. Thank you very much, but no, thank you. And you just document, patient refused the medication. And if you're as detailed as me, I kind of go a little bit above and beyond. So I usually also write patient refused medication after verbalizing understanding of what the medication is actually for. Um, but really, simply, you really only have to write patient refused the medication because therefore you're covered legally. You tried to give it, they said no, and that's their right. And they're covered legally because they have the right to refuse anything. That's part of their right here in the United States of America. I don't know about other countries, but here they have that right to refuse. The only time we have patients that don't have the right to refuse, unfortunately, are patients who have lost their rights because let's say they have been they're on like a psych review and they try to, let's say, commit suicide or try to harm someone else during that time frame when they're in the hospital. They don't even have the right to say, I want to go home, I want to leave, I don't want such and such a medication, because we may be giving them Haldol or something else to calm them down as they're just going wild and trying to hurt everybody around them. So they really don't, they've kind of lost their rights when they try to murder themselves or murder someone else. So it's a fine line, but there, you'll know when you get into your field and based on the protocols for that floor, um, what rights pertain to the patients and what don't, depend on what their diagnosis is and why they're there. Were they suicidal or were they just someone recovering from a heart attack? Well, what's going on here? And when in doubt, always ask. Don't assume anything. Ask questions. That's what your charge nurse is for. And God forbid your charge nurse has no clue, then you, the manager, will be next. Okay? The last one is the right evaluation. So, what that's referring to is assessing the patient's response to the medication, monitoring for both the intended effects of the medication and adverse reaction. Again, I'm going to go back to something very simplistic that you'll be giving all the time, which is a blood pressure medication. So many people out here with high blood pressure. It's not even funny. So, and there's people out here with really low blood pressures. We give midodrine to a lot of those people. Though the midodrine is what bumps up your pressure, because without it, you would be really low. Because a lot of times we have to bump up their pressure just to keep them living, unfortunately, because of whatever condition that they're going through. So the evaluation is, did the midodrine, which is used to bring up the pressure, I took the pressure, it was 90 over 40. I gave the midodrine, let's say it was, they usually come in 5 milligram tablets. So let's say I gave 15 milligrams as ordered. And now the pressure is 112 over 75 or over 70. Oh, thank God it worked. I'm evaluating the effects of that medication. Or let's say I check it, it's like, oh my God, it's now, it was, 90 over 40. Now it's dropped to 80 over 35. It didn't work. That's important, guys. I'm telling you, just because we give medications don't mean they work. People's bodies change all the time. There's always something happening within our body at any given time. Our cells are constantly active, constantly doing things. And if you're already ill, there could be other systems in your body that is crashing. And you're looking at this person just laying there, you're thinking, okay, everything's okay. He's the way he looked a few minutes ago. But yeah, something inside of his body maybe have just changed. And now he's not absorbing that medication properly. He could have just threw up. And you think, okay, why did the pressure not go up or not go down? And then you look on the side of his mouth and there's liquid there and the pill sitting there on the pillow, because when you walked away, he threw up. And that's why it didn't work, because he never really ingested it. Or worse, he did ingest it and it didn't work because something else is happening to him. So that's when you're jumping on the phone, calling the doctor, say, look, I gave this medication. The intended effect was for the blood pressure to go up or to go down. And this is the result. And nothing changed, because usually that's when the doctor's going to order additional medications to get that patient stable. This is huge. You need to always go back and reassess your patient and evaluate if whatever you gave them actually worked. Okay. I mean, literally, I had a patient once too who I gave insulin to based on the sliding scale. And for some reason, something was going on in her system and her sugar was going up and up and up. And something just like, you know what? Something about her, she's still showing a lot of signs of hyperglycemia. So let me just take another blood sugar just to check to see. Another quick finger stick to see how low her sugar came down to after I gave the insulin. I checked it. Her sugar had went up even higher. So I had to get additional orders for more insulin. And in the end, the patient ended up on an insulin drip. Okay. So they were in the critical care arena. They went from a regular 4, we moved into critical care because they need to be closely monitored if they have an IV dripping that has insulin in it. I mean, it was a really pretty bad for that patient. I mean, the patient did recover over some time, but yeah, you have to always go back and evaluate. So just remember, guys, that expanding our focus to these 10 rights bolsters our commitment to patient safety and minimizes the potential for medication errors. Now, what we're going to do is go through just a few quick little questions and a few scenarios to kind of just drive it home and put you in the right state of mind when it comes to medication administration. And, relax, chill, do your best to answer the questions. They are extremely easy. I kept it easy because I mainly just want you to get the concept and truly feel comfortable with knowing these 5 to 10 rights and how you're applying them every day. We're doing this every day. Okay, guys, let's get started with the questions. And if you haven't already done so, please click that like button. And if you haven't subscribed, please subscribe. Join us. You will learn a lot. And if you don't want to miss any episodes, also hit that bell for notification. During medication administration, what action should the nurse prioritize if the patient's identification wristband is missing? Is it A, administer the medication based on verbal confirmation from the patient? B, use another patient's identification band temporarily to proceed with medication administration. C, delay the medication administration until the patient's identity can be accurately verified. D, proceed with medication administration based on the nurse's recognition of the patient. The answer is C, delay medication administration until the patient's identity can be accurately verified. When there is a discrepancy between the prescribed dosage and the patient's recorded weight, what is the nurse's best action? Is it A, administer the medication based on the physician prescribed dosage? B, use the recorded weight to calculate a new dosage and administer accordingly? C, consult the physician to verify the correct dosage based on the patient's weight? Or D, administer a lower dosage to ensure safety without consulting the physician? The answer is C, consult the physician to verify the correct dosage based on the patient's weight. When the medication chart doesn't specify the route of administration, what should the nurse do? Is it A, administer the medication orally, as it is a common route for many medications? B, consult the patient's medical history for the usual route of administration? Is it C, contact the pharmacist to confirm the appropriate route for the medication? Or is it D, administer the medication intravenously to ensure rapid absorption? In this few second break, I just want to let you guys know thank you so much for listening to this channel and being a subscriber. And for you guys who haven't subscribed, please like the video, share the information with others, and also, of course, click the subscribe button. And if you hit the bell, you'll get notified of more recent video offerings. Thank you so much, guys, for your support. Let's continue. The answer is C. Contact the pharmacist to confirm the appropriate route for the medication. The prescribed dose of a medication is 250 milligrams, but the available tablets are 500 milligrams each. How many tablets should the nurse administer to the patient? Is it A, zero point 0.5 tablets, B, 1 tablet, C, 1.5 tablets, or D, 2 tablets? Since each tablet is 500 milligrams and the prescribed dose is 250 milligrams, the nurse should administer half a tablet because 500 milligrams divided by 2 equals 250 milligrams to achieve the prescribed dosage. Good job. A pediatric patient requires a medication at a dosage of 2.5 milligrams. The available medication is in liquid form with a concentration of 5 milligrams per 2 mLs. How many milliliters should the nurse administer to achieve the prescribed dosage? Is it A, zero point 0.5 milliliters? Is it B, 1 milliliters? Is it C, 2 milliliters? Or is it D, 4 milliliters? The concentration of the liquid is 5 milligrams per 2 milliliters. To achieve a dosage of 2.5 milligrams, the nurse should administer 1 ml or milliliters. 2.5 milligrams divided by 5 milligrams per 2 mLs equal 1 ml or milliliter. of the liquid medication. Well, guys, thanks again for joining us. And I really hope you got a lot out of this session and a whole new awareness for medication administration. And the reason why we had to evolve from the 5 rights to 10 to get you to think more critically about the whole situation. You are that last check. You're the last person protecting that patient against a medication that could cause them harm or something as severe as literally life and death. So this was a very important session. That's why I spent a lot of time on it, because you need to save lives. We're in there to save lives, not to kill people. And unfortunately, people are dying, at the hands of professionals because they are not abiding by these rights. These are the rights you need to stick with. And if anything else comes to mind when you're trying to protect your patient and do the right thing by your patient, then pause, talk to a doctor, talk to the pharmacist, re-question orders when you're like, you know what, this something is not quite right about this order. I just don't feel comfortable about giving this medication. I don't feel comfortable about encouraging a patient to take something that I don't even think he or she should be taking. If that's what you feel like, pause. Believe me, nurses' intuition is huge. A lot of times we have saved multiple lives and caught stuff that doctors haven't caught and pharmacists haven't caught because we used our brains, we critically thought about the whole situation and said, you know what? Something isn't right. I'm not giving this med until I do a little bit more research on this, ask a bit more questions, or see if I can even get the doctor to change the dose to something a little bit lower or something a little bit more safer in this particular situation. So thank you so much, guys. I really want you to send comments. If there anything you were confused about, is there anything else that you would like to learn about, or anything in specifics that you want me to review in general? It doesn't even have to be NCLEX related. It can be in general about nursing related in any nursing field that I have personally been on. I will definitely share my own personal experience as well. But if there's other areas that even I have not worked, I will have no trouble doing the research, of course, and getting that answer to you, because that's what I do. That's part of education, and we're always researching and looking up the most updated information, because information is constantly changing in healthcare. What we knew 3 or 4 days ago, or a few months ago, or a few years ago, is like a whole new ballgame now. You either find out new things, or you find out that you were wrong about some things. Whatever it is, they rewrite books, they rewrite textbook medication books, and they get it right. They may be adding more side effects as well if we've discovered more things about a particular medication or any particular thing in nursing in general. So please send your comments so I can see how you're thinking and where you're headed and what you actually need from me to provide and give to you via these videos on YouTube. Also, don't forget to like and subscribe. That helps us to continue to put out more and more videos to help people on YouTube learn and grow of no cost to them. Okay? Like I mentioned earlier in the beginning of the video, I did say I would provide an email address, contact information, so that you can reach out and schedule a much needed one-to-one or even a group session if you have a group of people or a group of friends or a group of coworkers who need to learn a little bit more. Definitely go email a SkillSnacks YT@gmail.com. Of course, the YT stands for YouTube. Makes it really easy to remember. SkillSnacks YT@gmail.com, and put your preferred day. At least give me 3 days to choose from, if you don't mind, for that first initial meeting, so I can. It's more of a consultation, so I can find out what are you looking to learn, and give us an idea of how much time it'll take to learn that information, how much time you need, and how good you need to be at it. Are you studying for an exam? Are you starting a new career in another field in nursing, within nursing? What are you looking to gain? Are you writing a research paper? What is it that you need from me to help you? That's what I need you to be more specific about in the email, as well as giving me a date and time, 2 to 3 dates and times for me to reach you and for us to do that. So I'm here for you just feel free to reach out. And again, thank you so much for watching us today, and hopefully you will join us again on the next video. Take care.